Dana Hawkinson is the medical director of infectious disease. And on my left is our vice president of system integration, Chris Wilson. Chris is really in charge of helping us put together our rural health network. And there was a really good question yesterday, and we wanted to follow up a little bit about what's going on in rural America. So I wanted to start out, first of all, just letting you know today, or as of last night, we had 37 positive patients with COVID-19 here at the University of Kansas Hospital, and we had 14 of those patients were on ventilators. So our numbers being about the same the last couple of days. Maybe that's a good sign, too early to tell, but we're hopeful. But first, let me just turn to Dr. Hawkinson. Dana, anything this morning? Special news, breaking news, anything cool?
Yeah, I think that we are starting to finally get to see randomized controlled trials, very well done studies looking at therapeutics for COVID-19. Plaquenil, that's hydroxychloroquine, that's been a popular one that we've been looking at, that's been popularized in the media. We are looking at it here. We have criteria and trials here at the health system, but also a large trial from China. So we're looking hopefully to get more data and really see if it's helping or not.
Yeah, there are so many trials and so much research going on across the country and across the world. One of the good outcomes, even as we have to distance and shut down travel, is the amount of collaboration going on internationally around trying to find therapies and new treatments and new ways of approaching this novel coronavirus. But Chris, I think that this is going to have a significant impact on rural communities. They're a little behind where we are in terms of getting the rapid rise, but we do believe it's going to go there. How is rural Kansas looking at this? What is your sense of what's going on out there?
Yeah, well, I think, Dr. Stites, one of the first things I'd say is we're always committed to improving the health of the state of Kansas, and we've been focused on that pre-COVID. And now during the COVID response, that need and that desire for us to do that has just escalated even more. It's just we're talking about different things right now. So we're talking about how to respond to COVID. And what we've seen, I know you and Dr. Hawkinson have been part of webinars the last couple of weeks. We've broken 2 webinar systems because there's such a desire for information and a hunger for updated information that we can put out across the state. And what I'm really pleased by is we can have a conversation in the morning between folks like yourselves and folks in Wuhan province or in New York, and by the afternoon we're able to share best practices from critical care teams across the world, really, and what our rural providers are looking for and helping us get the best information and best practices out there. I think from an incident standpoint, about half the counties in Kansas right now are in the Kansas City metro area between Johnson and Wyandotte County. Maybe across the state, we haven't seen as much of that curve hit many of the rural communities, but what concerns me is you do have a couple hot spots out there. So where you've got incidences of maybe 15 to 25 per 100,000 in the Kansas City metro area. There's a county in Kansas that has an incidence of 192 per 100,000, where you have, say, a nursing home outbreak where you have a very concentrated spread of the disease that could put a real strain on the rural health infrastructure that might be in that community.
Yeah, that's especially a concern when it does get into nursing homes, because we know, Dana, that once in nursing homes, the disease can really accelerate through a community that is especially vulnerable.
Yep, absolutely. We know, we've seen this started in Seattle. We know that close-knit communities and centers are very susceptible to having the disease and the infection go through various members and a lot of members of that community.
And of course that leads us to what our message is every day: stay at home, stay safe, socially distance. It really, really does work. There are some maps that were published in the New York Times today. We're looking at the relationship between social distancing and rate of rise. It is undeniable that those areas that have practiced distancing are seeing a slowdown in their rate of rise. So I do think, the evidence is so compelling that has to be our continuing, ongoing story as healthcare leaders, that we need folks to practice. And it's what we were saying the other day in that famous Wizard of Oz line: "There's no place like home." Well, we're open for questions. Anything that folks out there are wanting to ask?
This is Angie with KCTV5. Are you guys looking at sharing ventilators among hospitals if that need arises? Can you talk a little bit about the conversations taking place?
We have. And those conversations are ongoing, and the answer to that is yes. I mean, if let's say for whatever reason we didn't have ventilators and another hospital had an overwhelming number, or we didn't have the need for those, and another hospital had an overwhelming number, then we would do whatever it took to help make sure we keep people safe. The other thing is that most hospitals have looked at saying, gosh, what if push came to shove? Would we even consider sharing ventilators between 2, 3, or 4 patients? That's met with a lot of mixed reviews. There's just a lot of physiological struggles with that. I think everybody has that idea in the back of their mind, somewhere buried in their closet, but it's not something we want to do because there are a lot of struggles. So I would say we'll try and not do that, but I think everybody would go and share ventilators first. What we hope is that with social distancing, staying safe at home, when you're out at the park, maintain your 6 feet. Nothing, okay, I'm a physician, here it comes out. Nothing bugs me more, no pun intended. Nothing bugs me more than to go out and drive around one of the parks and seeing people congregated together or walking together or acting like it's another normal day. This is not a normal day. This is a pandemic, and that changes everything. And so trying to keep people safe is what we would need to do in order to lessen the impact of this crisis and quite possibly shorten the duration of the crisis. Because we don't know. I mean, we talked about this the other day. If we can make sure that R naught value gets down to 1, that's when these things start to disappear. And so what's R naught? R naught is how many people one person infects. So if one person infects 3 or 4 people, we're spreading the disease pretty rapidly. If it gets down to around 2, it's harder, and you get down to around 1, and that's when most of these things begin to die out, Dana.
That's when it stops. Yeah.
Yeah.
Absolutely.
So yes, we'll share ventilators between hospitals. We're hoping the supply chain continues to ramp up. We are seeing some areas that's beginning to occur, and we're hoping there'll be more ventilators out there for supplies. And the thing that people can do most of all is to help us shape the curve. And it's what we said yesterday. If you want to shape your future, shape the curve. Questions?
Hi there, it's Jessica with 41 News. I know you mentioned that this thing dies down when the R naught becomes 1. My question is, because I believe on a last call, one of you had said when a virus is new, it doesn't really know what to do with people. Does the strength of the virus lessen when that happens, or is it just going to be this as severe of an illness even down the line?
Dana?
Yeah, that's a very good question. That question takes into account infectious diseases, immunology. Again, we're always asked the question, if I get the infection, can I get it again? We've seen some reports of people possibly being able to shed the virus or maybe be infected again out of China. We don't know all the details or the data from that. We hope that certainly in the short term, for 3 months or maybe 6 months, you will certainly have immunity. We know that the first SARS, you were able to have antibodies for 2 or 3 years, and then after that, the antibodies decline in your body. But we don't know exactly what that means for infection-wise, and are you going to have symptoms? If you have symptoms, are they going to be less? Those are questions we still don't know at this point. We would hope that once your body has seen it, you are, in fact, immune. That was the initial thoughts by the CDC and Dr. Fauci. And we hope that's true, but we still have to look for that and get that data. So,
Next question.
Playing off of that a little, so just I'm one of those people who, like the rest of us, we're here, we're in the thick of this, and yeah, it's a bummer right now, but you look forward to the future. Are people, in the next year, say who are, immunocompromised or things of that nature, are they still going to have to be, I guess, just as cautious? How long does this really go on if you want to avoid, do you need to have those protocols in place so that you avoid getting it?
I think that's yours, but I have a follow-up to it because I want to spin off this, so go ahead.
okay. I mean, at this point in time, we really haven't seen an end point. Everything is being pushed out longer. The stay-at-home orders are being pushed out longer. The shelter in place. And until we get some more information on really what the virus is going to do here in America, as far as dying down or being not as prevalent as it is now, we really can't answer that question. I think for the short term, the next 3 to 6 months, absolutely, I think those precautions need to be taken by not only immunocompromised people, but everybody, and that's hand washing. Probably obviously there's probably going to be no social or mass gatherings for a little while, but certainly for the short-term future, I would assume and would hope that especially immune-compromised people would be taking extra precautions, yeah.
And I think that, I have a clinic, I've said before, full of cystic fibrosis and quite a few lung transplant patients that we follow up with. We're telling those folks to stay home. And when it comes to the question, how long do we do that for? Once the virus begins to die out, your chances of contacting it drop. And that's when we'll start saying, okay, let's loosen things up a little bit. But what we have to practice is a little Harry Potter-esque. It's constant vigilance. Because what you want to do is, if you start to see it rise, then you got to try doing the distancing thing again. But we know that influenza is seasonal. We know that by and large coronavirus is seasonal. So our thought is this will probably be a little like that. And as we build up more immunity, and then once we get an immunization to it, then I think it's going to be safer and safer. But there's a really important lesson here. You can shape this curve. You can shape this curve. Distancing is part of it. But the other really important part is washing your hands and not touching your face. And the good news is that's going to help you with influenza, rhinovirus, metapneumovirus, and any other whatchamacallit virus that may be out there, because they all have the same way of going. And so if you want to make sure you don't get whatchamacallit virus, then the thing you need to do is follow the same basic principles of infection control. They really do work. They're boring. You're tired of us saying it. We try to find a new way to say it every single day so it sounds a little entertaining. But the reality is, it is what works. So if you want to shape the curve, you got to shape your behavior. Next question. You don't want whatchamacallit virus. It's bad.
I have a question about droplets that may be a really stupid question, but I was talking about, this is Taylor at 41, was talking about somebody, this was somebody this morning in our newsroom, and we were talking about masks and whether or not to wear them, that kind of thing. And again, Dr. Hawkinson, we appreciate your time this morning talking about that. But I didn't know, and I don't know if I've ever heard someplace along the way, if the way I'm potentially transmitting or sending out those droplets is only when I cough. Is it when I talk? Is it any time I open my mouth? That's a potential. How am I potentially spreading anything that I may or may not be carrying?
Okay, I'll take this one. Man, I'm going to mess with this question just a little bit. I wanted to say, well, how loud do you talk? And are you yelling? And are you like...
I talk very loud.
You have a big mouth. I have a big mouth, so I probably spread it everywhere. No, so listen, how much you spread and how far you spread is directly related to the force of projection you have. Coughing is actually enormously powerful, because the way we do that is you take a really deep breath, and you don't, your lungs aren't a muscle, right? So the lungs don't force air out because it's a muscle. They force air out because they're meant to be smaller, not bigger. So you have to, your muscles work to open up your lung, and then elastic recoil closes it. But you help that force of it when you close the back of your throat off, and that's how you build up the force around the cough, and that allows you to exhale or cough out a bunch of phlegm all at once. And that's where you spread it the furthest. But generally you don't spread it that far, because most droplets tend to be pretty big. Now, there are some people that say, oh, you get dry, you can cough it in the air, it can hang in the air and all that stuff. Yeah, but the amount of that is really small. That the amount is really caught up in bigger droplets, and bigger droplets tend to travel a few feet and fall flat on the ground. Really, it's about 3 to 6 feet. And that's with a cough. So a routine breath goes out much less, and you don't have the same volume because you're not coughing out mucus. So you'll get a little bit out there, but not like a big cough. And if you put it into your elbow, we tell you all the time, like that, into your elbow, because what happens then is all the stuff goes into your elbow. Then after your clothes are a little saturated with, whatchamacallit virus, but before that, it's really, if it gets lodged in your clothing, gets lodged in the nook of your elbow, then you're really a lot safer. Now, you've seen some stuff out there that the CDC is contemplating suggesting that people wear masks when they go out in the public. And the reason is that if you do that, you may decrease the amount of virus you transmit, or if you're at a table or somewhere and you cough and it doesn't leak out as much, it gets caught in the mask and drops there on there. The problem is that science is a little soft on medical grade masks. It's not soft, but on homemade masks, it's a little soft. And then we're a little worried that if you go to take off the mask or reposition it and you don't know how to do that and you touch the mask is loaded with virus, and then you touch the countertop, you may have spread more like that than if you had just coughed. And so unclear where they're going to land on that.
Yeah, I would agree. And I think, the CDC, the stance they're taking right now, the thoughts that they're having, I think it's still consistent with what we've said all along here at the health system and what the CDC has said. If you're ill, certainly wear a mask. That will help from infecting others. If you're not ill, you don't really need to wear a mask because it's not providing you any protection, especially probably some of these homemade masks. But what their concern is that some people can certainly spread the disease if they're asymptomatic and they don't know they have the infection yet. And so that is the main crux of possibly why we want to go to most everybody wearing the mask, because you could still possibly have coughs. Certainly it's allergy season as well, and so people are coughing from that. They can certainly have allergies and have COVID as well. So I think their stance is continuing to be consistent. They're just looking at other avenues to really stop the spread.
Next question. You're not asking something. That gives me the chance to turn to Chris Wilson and say, Chris, what's the biggest question you're hearing out in rural Kansas, and what's their biggest concern?
Yeah, supplies is probably the thing that's on most healthcare providers' minds in rural Kansas. So we hold a daily call every day with our system, and we go through a list of topics like patient updates, and supplies is right there at the top. And so certainly personal protective equipment, ventilators. To the question earlier, we do an inventory every day of all the ventilators that we have across our health system, all the anesthesia machines we have across our health system, how many are in use, just so we can make sure and understand sort of what the universe of supplies are out there right now. That's certainly one. I think another big question is the application of protocols in the rural setting. And so we get a lot of questions about, does this PPE rule apply differently in a setting that we might have that might not be in an urban setting, but rather in a rural environment like a critical access hospital or a rural health clinic. And so then we have to collaborate with our expertise here in Kansas City and across our system just to make sure that we're applying those rules in an appropriate way in a rural setting. We have a great resource with Dr. Bob Mosier, former Secretary of Kansas Department of Health and Environment, who's leading a lot of our efforts of helping make that translation to the rural setting. And then, another question that we get quite a bit is just what's it like? I think because the cases haven't occurred yet in many of our rural communities, they haven't some, but in many of our rural communities they haven't occurred yet. I think they just want to know what's the experience like. They really do want to hear from folks on the front line who are taking care of these patients, asking very specific clinical questions that folks like Dr. Stites and Dr. Hawkinson are able to answer about, when is intubation appropriate? How do we handle transfers? What's this process going to be like for family members as they get moved from one facility to the other? So we certainly hear a lot about that. Then the other big topic is a little more daunting, and it pre-existed COVID, and that's sustainability of rural providers in the first place. So prior to COVID, 3/4 of the hospitals in Kansas were operating at a negative margin, and so they were already many hospitals were already in a precarious financial situation. And so COVID is only going to exacerbate that situation as they do things like cancel elective surgeries and reduce the in-person clinic volume. And we really need to encourage our state and federal elected officials to make sure not forget about our rural providers in that respect, that rural sustainability is going to be a big piece of how we recover from the COVID response for our rural providers. And maybe the final kind of silver lining that I see out there is virtual health.
I was just going to say, you've got to talk about our telemedicine thing, because I think this is really the untold story of a silver lining in there, especially for rural, because we're opening up our telehealth network across Kansas, trying to have our providers are ready to see patients from throughout the state, whether you're part of the health system or not.
Yeah, absolutely. So I like to think of it as high tech, high touch. So
Yeah.
maybe before coronavirus, it was there were some providers that were interested in telehealth. Some were providing it. I think we're seeing what we thought was going to be a 2-year change to telehealth occur in a matter of 2 weeks.
Yeah.
And that transition has been rapid. It's been significant, and I think it's going to be to the benefit of a lot of our citizens across the state, in particular because maybe historically they didn't have access to some of these specialties. That now that we have the infrastructure and the processes set up to deliver access to a lot of specialties and subspecialties, are going to be able to have access to that service closer to home and get the services they needed even before the COVID response was in place.
And just to say, the government, I know every level of government is trying to figure out how they respond to this. One of the good responses has been the loosening of the regulations around telehealth that allowed us to do stuff. So in tradition of the great Aretha Franklin song, Who's Zooming Who, we're all on Zoom, and what's one of the platforms you can use with telehealth. And so you're Zooming with your patient, and at the meantime, you're putting stuff into the EMR. It's pretty slick, and I think it is going to revolutionize care in rural America, and I think that's actually a great thing. And I know we are, as I said, we've rolled that out throughout our health system. We're doing it beyond, and so really a strong platform. Let folks be part of the University of Kansas health system, whether they're close to one of our hospitals or not.
Yeah, I think that's right. And if we get asked a lot, what can we do to help from a lot of our patients and citizens? One of the things I would recommend would be to try a telehealth visit, to be open to that type of visit, and I think you'll be pleasantly surprised. My 70-plus-year-old father is looking forward to his first telehealth visit later this month, and he's pretty excited about it. And I think most people will be really encouraged by what they receive from a service standpoint as a result.
Yeah, my 87-year-old mother-in-law has been out showing other folks how to Zoom, so that's pretty cool. All right, other questions?
What types of things, since you're talking about telehealth? Oh, go ahead. You go ahead.
Oh, thanks. Thanks, Jess. This is Fox 4. Good morning, everyone. I had a question about people in recovery or people who have recovered. More and more people are recovering. They're going back into the population. Do we believe that maybe they are still capable of spreading this virus, or are they getting false information that, hey, you've had it, you're fine, you can start going back to your regular life?
You bet. Let's take that on.
How are we dealing with people?
Well, and I just wanted to say we discharged 3 patients yesterday who had recovered here, so I just want to say that's good news. We do want to talk about how this virus isn't so magical that it can do anything it wants, and I'm going to finish with that in a little bit, but we did discharge 3 patients yesterday, and we did get somebody off the ventilator, so that's awesome.
Yeah, that's a good question. So as far as discharging, certainly there are different methods and different strategies which the state health departments use or the CDC gives guidance for as to when you can go back to quote-unquote your regular life, when you don't have to self-isolate at home anymore. Those are based on testing, so you can either test. You need to have 2 tests within 24 hours apart that are negative. Or there's a symptom-based strategy in which you've had symptoms for a prolonged period of time. After your symptoms are resolved, then you could possibly go back. I would encourage anyone to really contact their state or their local health department to see which guidance is preferred. The second part of that question, however, is, are you still shedding virus? That is a very real concern. There has been numerous studies which show people can shed virus for up to 21, 28, and even outliers even longer than that, 35-plus days. However, we're really not certain that you can, how infective you are at that point. I know that's a big if and a big concern, but we also know you shed other cough and cold viruses such as influenza and other cough and cold viruses for prolonged periods of time, or you can. So that is still one question which we are working with. And again, I think we're still looking for guidance from the CDC, but also if you are well enough, or if you've had symptoms, and if you've gone home from the hospital, or if you've just stayed home with your illness, I would encourage you to contact your local health department for further guidance on that.
And from our standpoint, with our employees who are positive,
Yep.
how long do we wait here in the health system before we say you can come back to work?
Yeah, at this point in time, we are typically now waiting 14 days from symptom onset, and then we are allowing you to come back to work, provided you're wearing a face mask during that time as well.
And we kind of like a negative test out there sometimes. So
Sometimes, yeah,
Yep,
we're able
depending
to
on
do
the
that.
patient. Okay. So yeah, that's one time where masks are probably helpful a little bit, just to give a little bit more reassurance to a patient and to the community in which they live.
And that
So-
is from guidance from other major centers who are seeing infections as well.
Yep.
So we're taking
Yep.
guidance from that.
They're ahead of us on the curve. Good question. Next question. I heard another telehealth
Going back
question.
to the telehealth
Yep, yep.
a little bit, because I was offered that opportunity, and I thought, well, this should probably be looked at first. And what types of things shouldn't you do telehealth calls for? When would you need to go in?
Question.
That's a great question. So I think, for example, if you broke your arm, obviously that's probably not going to be a great telehealth visit. So there are things that are more surgical in nature. I think that's really one of the most important parts. And then if there are other things that are going to be critical in a physical exam that you can't tell just by seeing. So if you've detected let's say a new breast lump, that's a little harder to do by telehealth. If you've had a new, a lump in your groin, or you feel like your abdomen is really sore or tender, those things are harder to do by telehealth. There's ways we can get to it, but really those are probably the things that are most concerning. And I think the key is to talk to your physician's office and say, here's my symptom, can I go ahead and do a telehealth visit with that? They may start with the telehealth as a screening visit and then make a decision on what to go from there. And clearly, if you're acutely ill and you think, gosh, I got to go to the emergency room, it's probably better to just go ahead and go to the emergency room like that. Any other guidance from our team?
Yeah, I think that's spot on, Dr. Stites. Yeah.
I think the physical exam for certain conditions and complaints is vitally important. Obviously, talk with your primary doctor, and they should be able to steer you in the right direction versus telehealth versus coming in.
I think
Yeah.
right now in the response that we're in, I think doing the telehealth visit could help give you direction on
Yep.
where you might need to
Yep.
otherwise go, and
I
help
think
make
that's right.
preparations for if you do physically need to go to someplace. It allows that place to make the appropriate preparations before you would come in.
And around COVID-19 specifically, I think a lot of it can be done through telehealth. If you start to feel more shorter breath and it's getting a lot worse, then you got to go to the emergency room. But otherwise, you can check in with your physician. We have a COVID-19 follow-up clinic that we're running through telehealth, and I think that works pretty well. So I think we have time for one or two more questions before we close out. Anyone else out there?
I'll go again.
This is Melissa with 41. One of our viewers asked a question on Facebook. I know we talked about masks, but what about gloves? Should the public be using gloves and wearing gloves out in public when they have to run to the grocery store, or is that actually going to make things worse?
Yeah, great question, Dana.
I would agree with you. The same thing as with masks. The ultimate thing we want to do with any of these interventions, whether it's gloves or masks, is continue to maintain good hand hygiene and not putting your hands in your face. If you have masks on, if you have gloves, you may feel a false sense of security. And so even with gloves, you could be touching things, either winter gloves or driving gloves, or some people are even out in public wearing latex gloves. If you're still touching things and touching your face, everything that you're touching is just getting caked onto those gloves. And so you're still putting them into your face. So certainly, if you want to wear gloves out of an abundance of caution, I'm not going to tell you that it's wrong or you can't do that, but just understand that when you do that, you are still getting debris and microorganisms, whether it's the virus or other bacteria, on your gloves. And if you're touching your face and putting the hands there, you're still going to be able to contaminate yourself. So.
And then you got to still take off the glove.
Then you
So
take
just make
off
sure
the
you
glove.
wash your hands after
Yep.
you take off the gloves, because there's a good chance those gloves are going to have whatever your hands would have had on them. And gloves don't really have natural defense, right? They're just a barrier. Your hands actually have some natural defense set up in
That's
how
what
your
the
skin
skin's for.
works.
Yep.
So, next question, last question. I thought I heard somebody else from a moment ago. Otherwise, I'll ask a question. Chris, one of the things I think that's true out in rural Kansas that we hear a lot about is what happens if I'm a critical access hospital and maybe my average census is 2 or 3 patients, and I have somebody who goes on a ventilator. We don't do ventilators in those small hospitals. What do they do?
Yeah, I think they need to consult a critical care team that might be able to provide them some advice on how to transfer that patient to an appropriate setting. If they don't need the ventilator, many of the symptoms of COVID, as you know, Dr. Stites, can be managed in a lot of these facilities. But if they do get to that point in the critical care continuum where ventilation is required, that's when there needs to be a consultative visit with a critical care team and a transfer considered.
Okay. Final thoughts, guys.
Yeah, I can't allow you to be the only one with the pop culture reference
Oh,
today.
jeez, here I go.
I mean, you
just
brought
got
in
to
the
talk about
great
Harry
Aretha
Potter.
Franklin.
I did, that was pretty.
I
and
like
Harry
Aretha
Potter
Franklin.
today.
Yeah,
Two
the
in
Harry
one
Potter's
time. Two in
okay.
one. Yeah, not bad.
But as I was flipping through the channels yesterday after we got home from a late day and many meetings, the Terminator was on.
Oh boy, here we go.
So we all know the Terminator, and we are trying to get out how to best represent our voice and our guidance on what to do and how to stay healthy. Well, if everybody's ever seen the Terminator, listen and understand that the Terminator, i.e. the virus, is out there. It can't be bargained with. It can't be reasoned with. It has no remorse. It has no pity. It is in the large cities. It is in the rural communities. It can infect everyone, and it won't stop. It won't stop until there's no more people to infect. And so the best way to allow it to not infect anyone else is to social distance and physical distance and stay at home.
Chris.
Just because rule is smaller doesn't mean it's easier with respect to the virus. They're just a little bit different challenges that we face, but stay at home and social distance still equally applies in the rural setting as it does in the urban setting. And we need our rural citizens and our rural providers need that as well to be able to respond to this virus the best we can.
So I'm going to play off your pop cultural reference. You can be the Terminator too. You can be the Terminator too. This virus has somehow been given superpowers, but it doesn't have superpowers. It's mean. It can take your life. But it doesn't have superpowers. It can't jump tall buildings. It can't fly through the air in measurable distances. And it isn't made of steel. It's a virus. And so all the basics still work. So you can shape the curve, and you can keep yourself and your family and our world safe by being the Terminator. And the way you terminate this infection is the same thing we've been saying. Wash your hands. Don't touch your face. Cough into your elbow. Keep your distance. Shelter at home. There is no place like home. Thanks for your attention today. We'll see you tomorrow.
Thank you.